There have been a number of preclinical studies using human cells in the test tube, using experimental animal models that have indicated that JAK1 and JAK2 are potential targets for intervention in prevention and treatment of graft-versus-host disease. Based on the preclinical and clinical studies, the REACH1 trial was designed and recently concluded, reported in the literature, and the use of ruxolitinib was approved by the FDA. 49 patients with acute GVHD that was steroid refractory or steroid dependent were treated. The response rate at day 28 was 54.9%. And many of these patients survived, among those that we never thought could actually have a return so advanced and so life-threatening their graft-versus-host disease was. Since there are no other drugs that are FDA approved for treatment of steroid refractory or dependent GVHD, the REACH1 data is practice changing. And we have all started to use ruxolitinib for treatment of patients that are steroid refractory or dependent. The starting dose of ruxolitinib is 5 mg by mouth twice a day. If after 3 days we don't see toxicity, we can increase the dose to 10 mg twice a day. The toxicity of ruxolitinib is primarily hematopoietic, and we observed neutropenia, thrombocytopenia, and anemia. We have to be careful about escalating the dose in patients that have any evidence of hematopoietic compromise. And in addition, if patients are on a stable dose and develop new onset of hematopoietic compromise, neutropenia, or thrombocytopenia, we have to either decrease the dose or even hold the dose until the toxicity is reversed. I have used ruxolitinib for treatment of steroid refractory patients, and the effect of ruxolitinib is over and above of what we have been used to see with any other agents available to us. I have had patients beyond the point of expected return that actually have begun to improve. The median improvement time in the study was 7 days, and that matches my observation. The responses are usually long-lasting, but upon taper of glucocorticoids or taper of the ruxolitinib, flares may still occur, and responses, especially in patients with severe disease, are not invariable. The next question in the development of clinical ruxolitinib for treatment of steroid refractory dependent acute GVHD is to show that the treatment is actually better than alternative standard of care. There is no single standard of care, but the available best drugs as chosen by individual centers will constitute the control arm on the REACH2 trial. And we will be able to compare results of ruxolitinib to available best therapy. This is a worldwide trial that will be enrolling patients up to a little more than 300 of them, and results, as I understand, will be available later in 2019. The REACH3 trial is actually a randomized, worldwide clinical randomized trial that compares ruxolitinib against best available therapy for chronic graft-versus-host disease. Since many patients with acute graft-versus-host disease develop into chronic, this is definitely looking at meeting an unmet need of patients with severe acute and chronic GVHD.